Good evening. Welcome to our webinar related to COVID-19, organized by the Portuguese Pulmonology Society. Today, we are going to talk about the topic post-critical patients with COVID-19, from extubation, decannulation to rehabilitation. We have seen a lot of discussion about the approach of critical COVID patients with ICU admission and invasive ventilation. Some of these patients eventually died. However, a significant percentage of patients improved and progressed to a phase of ventilatory weaning, to extubation or tracheostomy. At this stage, we have an important concern: safety of healthcare professionals due to infection risk. Since some patients still positive to COVID-19, and extubation and tracheostomy are an aerosolization generating process, as well other techniques such as non-invasive ventilation and high-flow nasal oxygen. We also know that respiratory rehabilitation is essential to rehabilitate these patients and assist in this process of extubation and decannulation. But it can also be compromised by the limitation inherent to isolation of the patients due to infection risk. We have some limitations to assessing respiratory function and to carry out the therapeutic intervention related to respiratory rehabilitation. So to help us to clarify these issues and share your experience, I'm pleased to introduce our speaker, Dr. Elise Morawiec. Dr. Elise Morawiec works in the pulmonology service and intensive medicine, Réanimation, groupe hospitalier Universitaire Pitié-Salpêtrière de Charles Foix, Paris. Thank you so much for accepting our invitation. In addition to our speaker, I am also pleased to have the presence of Professor Dr. João Carlos Winck and Dr.ª Lígia, who at the end of the presentation will address some questions. Professor Winck is Associate Professor of the Medical School of Porto University, and he is a chair of non-invasive ventilation of the European Respiratory Society. Dr.ª Lígia Pires is an intensivist and pulmonologist at the Centro Hospitalar do Algarve and was Secretary of the Acute Critical Care Group of the European Respiratory Society, and actually is the coordinator of the recent created Respiratory Critical Care Group of the Portuguese Pulmonology Society. I think we are going to discuss very pertinent topics, sharing experience and knowledge related to post-critical patients with COVID-19. So I invited Dr. Elise to initiate the presentation when we are ready. You are ready?
Yeah. Okay. Obrigada for having me, sharing this with you. So, I work in La Pitié-Salpêtrière, which is a quite large hospital in Paris. It's one of the largest hospital in Europe. So we had in the Paris area was one of the areas where there are the most cases of COVID in France. So we've been very involved in dealing with this pandemic. Okay. So quite early on, we had to deal with this first question about how we're going to do to deal with this huge amount of patients that we have to take care of in ICU. So that was our first problem, and then more recently we had another problem, which was how we're going to deal with this huge inflow of people who coming out of the ICU and that need some form of rehabilitation. So that there's two questions that we had to answer in a couple of weeks' time. So I'm just going to start explaining you how we did things in La Pitié, so that you can understand a bit more about what has happened and how we managed it. So there were already a couple of different ICU units in La Pitié because it's a such a big hospital. And so what we did is that we progressively transformed most of our ICUs and even increased our total number of ICU beds to take some COVID patients. And we managed to do this. So we managed to do this and to go up to 120 beds at the peak of the pandemic. And we were able to do that because of a massive deprogrammation of surgical activity and reallocation of the staff, the beds, the ventilators, to have more ICU beds. We had two different kind of units that we used as a step-down units. This post-ICU rehabilitation unit that we already had, which is a unit which takes care of patients who have difficult weaning that are tracheostomized, and usually we have 6 beds, and we doubled that. And in this unit, we take patients from our ICUs, but also from ICUs from all over the area, and we only take tracheostomized patients. And we created a new unit that we call the step-down unit for just normal regular weaning. So it's sort of an ICU with a little less staff and resources, and we take the stable patients in the second phase of the disease for weaning as we do the usual way in the ICU. We also had what we called intermediate or acute care units, which were not ICUs, but were units where we put patients who were on quite a lot of oxygen from above 4 liters per minute, and those units were also able to provide CPAP, and that's where we would put the more severe patients that were not quite needing ICU yet. So mostly people, some of them had to be transferred to the ICU, and some of them did not, and also that's where we would preferentially transfer the patient after they've been extubated in the ICU. And after the first patient were released out of the ICU, we realized that we had to transfer them very early, sometimes the next day after extubation, and we're a bit concerned about how this would go and if some patient would not really been taken care of well in just regular medical wards, because they were the only place where they could go. So we created a post-ICU team that was mostly made of medical students, and they would go with a checklist and a sort of a screening tool for problems. They would go see the patients that were, after they would be released from the ICU on day 3, day 7, and every week, and they would go see and check a couple of things on the respiratory, nutritional, neuropsychological, and they would do a sort of small motor assessment to see what problems we had, and to coordinate the intervention of psychologists, dietitians, physiotherapists, to make sure that every patient still had some kind of rehabilitation intervention. So our first program was to increase the number of beds, so to increase the number of beds, so that's what we did. But also one of the ways to have more ICU beds with the same number of beds is to reduce the length of stay in the ICU. So to do that, of course, you have to extubate the patient the earliest that they can be extubated. So for that, what is advised, of course, is to apply the usual recommendation for fastest weaning. The main questions is this disease, does it have any particularities that would make some of the things that we usually do to facilitate weaning, is there something that would not be appropriate in this specific setting? And we tried to develop for units that were less used to it to have a weaning or extubation protocol to make things go quicker. Another way to reduce the length of stay in the ICU was to transfer the patient early after extubation. And of course, that comes with a safety concern, because usually, you know, that patient after extubation, we keep them in the ICU for a couple of days just to make sure they're doing better and before they can get transferred. And here we had to transfer patients very early, so that was a concern. And one of the options for shorter ICU stays to have more beds available is to transfer stable patients in a weaning unit. And one of the questions was, should tracheostomy be part of the strategy, and should we have sort of a strategy of early tracheostomy and transfer of this patient? That's a really important question, and we're going to develop on that. So, you know, the usual interventions that are discussed and are proposed and that have been proven to improve weaning in the ICU are usually to have an adequate management of sedation drug and not to use too much sedation drugs, to have systematic interruption of sedation, systematic use of spontaneous breathing trial. Having a weaning protocol in your team also helps for faster weaning of patients. Having a process of diagnosis and treating weaning failure causes, such as, for example, cardiogenic pulmonary edema. Early rehabilitation is also one of the things that was proposed to facilitate weaning in patient, and also one important thing that we usually do is to do post-extubation NIV in certain categories of at-risk patients to sort of consolidate extubation and to limit the risk of post-extubation failure. So of those sort of usual intervention, where some of them appropriate and not appropriate for COVID, what we found is that COVID pneumonia has a slow evolution. Most of the patients require about 2 weeks of mechanical ventilation. So it's sort of slow to heal. Also, the patient also require a really heavy dose of sedative drugs. And they're really difficult to sedate, so we have to use a lot of sedation, a lot of muscle blockers. And there's also a high prevalence of delirium when you try to withdraw the drugs. So we found in our experience that those intervention of systematic sedation interruptions were usually not a really good idea, especially early in the course of the disease, because the patient would wake up and it would just not work really well. So we don't think that, in our experience, those interventions that are usually recommended should be more cautiously done in the case of COVID pneumonias. The other thing that we sort of did a bit differently than usually was the use of post-extubation NIV for at-risk patients. So we, because NIV is, like you said, is an aerosol generating procedure. So we still, like we did it, and we chose to do it for the patients who were at risk, in line with the recommendations. So people with cardiologic problems, or people with respiratory problems, or old patients. The thing is, we took some precautions, like we only used double branch circuits, and we didn't use monobranch leak NIV. And we had a whole protocol for nurses and precautions on how to set on and off the NIV, would put on the mask and then turn on the NIV, and the opposite when they were taking it off, to avoid the exposure to aerosols. What we found is that most patients that we treated in the ICU were around like 50 or 60, and not a lot of patients had comorbidities. So actually not a lot of patients were in that category of at-risk patients. So we didn't do a lot of post-extubation NIV not because we were not for concerns about safety, but simply because they didn't seem to be needed. This is just to show you an example of the weaning protocol that we use in our unit. So this is really just not really different from what we usually do. It's screening patients for weaning, performing spontaneous breathing trial, and depending on the results, extubating the patient or try again the next day. So, and that's the same thing that we do. I think one of the important thing about the COVID is that everyone, since it's a very different situation, everyone is concerned about how they should change their practice. And I think that on the opposite, it's really important to stick to what you usually do, because that's what you do well, and you want to be efficient in that situation and not to do things really differently from what you do them, because it's ARDS, pneumonia, and that's what you know how to do this when you work in an ICU. So now the question of tracheostomy, which was a very important question, since those patients have ARDS and sometimes very severe ARDS, they are very severe patients initially. The median time on ventilation is rather long. It's 15 days, and we use a lot, very high doses of sedation and muscle blockers, and that's something that was reported by a lot of teams. So there were concerns that because of that, we would have a lot of weaning problems and a lot of ICU-acquired weakness. And what we found was that actually the prevalence of ICU-acquired weakness was much, much lower than what we expected. And we didn't really had a lot of real weaning difficulties. The real problem with those patients was mostly discontinuation of sedation drugs. But once this problem was okay, that we didn't really had a lot of real weaning difficulties, because patients were mostly young without comorbidities, and they had just one. They just had pneumonia, but they didn't have sepsis or things like that. And I think that's the reason why we didn't have real weaning issues. So what it means is that most patients, according to usual standards, most patients won't need a tracheostomy. So one of the question was, should still we tracheostomize patients because the situation is different and we're facing a pandemic, and maybe we should tracheostomize patients so that we can release them earlier in the ICU and take care of more patients. And that was a question that was discussed, and people are at different point of view and different experiences. Our experiences was clearly that we do not recommend early tracheostomy for the patients, because early in the course of the disease, like the patient are COVID positive, and tracheostomy is an aerosol generating procedure, so that would expose the medical staff. And at the beginning of the course of the disease, the patients are very hypoxemic, so it's actually could be a dangerous procedure. What we also found was that early transfer in a step-down unit was anyway rarely possible, because of other problems like acute kidney failure, or because of those problems with sedation and delirium. So anyway, even with the tracheostomy, it would still be a problem, because the step-down unit was somehow less staffed, and it would not be possible even with the tracheostomy to transfer the patient for a lot of different problems. Also, in France, there's usually quite a low knowledge in tracheostomy management among healthcare workers. So actually transferring tracheostomized patients to people who are not used to take care of tracheostomized patients is not automatically something that's considered safer, because one of the reason people wanted to tracheostomize were like, oh, we're going to tracheostomize the patient, then we can transfer them and it's safer because we won't have accidental extubation. I'm not sure it's safer if people don't know how to deal with a tracheostomy. And also another argument is that if a tracheostomy was not needed, weaning would probably be longer with the tracheostomy than with an extubation. So that just defeats the whole purpose of tracheostomy for faster weaning. So in the long run, it's not really, in my opinion, it's not really a good solution. And you would expose a patient that does not need a tracheostomy to the potential complication of a tracheostomy. So in our experience, in our advice would be just to stick to your usual practice and only use tracheostomy for patients with prolonged weaning only, for the patients who have a real weaning problem, because it does not really, if you don't have, unless your healthcare system has a possibility to take care of tracheostomized patients more easily than keeping them in the ICU, it's not really a solution. So in our experience in our ICU, we've treated from the beginning of the COVID in RCU, we treated 110 patients and we only tracheostomized 2 of them that were, and we have a tracheostomy program. We have 2 programmed for next week, but they're both on patients that are over 40 days of ventilation. So that's pretty much a standard indication for tracheostomy. In our post-ICU for tracheostomized patients, we had 35 patients that came from different ICUs, and their median length of stay in the ICU was 18 days, which is not so long. And usually in that unit, the median length of stay in the ICU is more about 40 days. So they're not the same patient. They're not so severe, and the time to decannulation in this unit was 7 days, which is rather short. And the people would only stay for 10 days. Usually they stay for a month. So what we can see is that the tracheostomized patient that we had, mostly for other units who had a strategy of early tracheostomy, were less severe than the ones we had usually, and they were really fast to have a favorable outcome. And our feeling was that most of them wouldn't have needed this tracheostomy and could have been weaned just normally. What we're seeing though is that since the epidemic started about mid-March in France, we're starting to have patients that are coming out of the ICU with over 30, 40 days of ICU, and it's a different story because those patients are more like usual difficult to wean patients. Usually it's patients who have been on ECMO for a long time, etc. So they're more like the tracheostomy in these kind of patients is more like the usual practice. So instead of advocating for, because one of the questions in the organization of healthcare in France, we were considering, should we develop that kind of post-ICU units for tracheostomized patients, and how can we expand the beds in those units? And it's very complicated because the type of care for those patients really demands some kind of expertise, and it's really takes a long time to train the staff to properly take care of those patients. So we found that because of what I've been telling you and because of the characteristics of this patient, it was more interesting to have to create some step-down units that were just like regular ICU, but for stable patients that are close to the weaning phase, that would be maybe less staffed, less well-equipped than normal ICUs, with no epuration, no extrarenal epuration, no sedation maybe, or no prone positioning. So a little bit less resources in those ICUs, but they would be more dedicated to the weaning phase. And so the ICUs would transfer the patient into those weaning units and be able to take more acute patients. So we found that worked better this way because it's more what people are used to do. So it's easier to put in place than really specialized unit for tracheostomized patients. So the only thing about those units is that they are dedicated to weaning, so they should be staffed with people who are a bit knowledgeable, who are trained, specifically trained about ventilation, non-invasive ventilation, and the ventilators can be, because of course one of the issues is that are we going to have enough ventilators for everyone? So we can use the ventilators that are less performant than big ICU ventilators, but still what is important here is that they still need to have a good, good weaning modes, good pressure support, good triggers, and things like that, because that's the main activity in those units. Sorry. Now I'm just going to say a word about what we've seen about the patients that are coming out of the ICU and how they're doing. So we, sorry, I didn't have the time. I wanted to have more data than that, but I didn't have time to reactualize it. But that's what we had about 10 days ago. We've been able to see 34 patients that were coming out of the ICU. Most of them have had, 80% of them have had mechanical ventilation for about a median of 11 days. What we found is that after getting out of the ICU, 1 of 4 out of those patients was diagnosed with ICU delirium, which is a pretty high prevalence. But this state of delirium usually resolved by itself in a couple of days, and only in a few, 1 or 2 patients, it stays for more than that, and they're being investigated by neurologists to see if there is some kind of COVID-related encephalitis or something like that. But what was striking was this high prevalence of ICU delirium. 3 patients were diagnosed with acute stress syndrome. You know, this condition can, if untreated, then this condition can derive and give a post-traumatic stress disorder. What we found was that on the I told you the patient didn't have a lot of ICU acquired weakness, and indeed the MRC score at 1 week was at 56, a mean of 56. So 1 patient at 21, but it was a patient, like, it's not really, the minimum was 21, but it was a patient who had already hemiplegia, so it's not really irrelevant. But really what is quite striking is that most patients had a very good motor recuperation, and on the first week, half of the patients were able to go to the bathroom on their own, and an additional 30% were able to walk with the help of someone. So that was pretty encouraging. What we also found is that even though proper nutritional assessment was lacking in most patients, we had the weight, were able to evaluate the percentage of weight loss in about half of the patient, and we found that it was pretty severe because the median was a minus 8.6% of body weight, and we had patients that had lost up to 20% of their body weight, which is extremely high. And we didn't have we didn't find that there were a lot of patients that had persistent dysphagia. It was noted in 3 of the patients we followed. Only 1 of them had a diagnosis of encephalitis. 1 of them had pre-existing myasthenia gravis, but for most of the patients, it really wasn't a problem, and most of them were eating normally at 1 week. We also found that a subset of patients displayed persistent dyspnea or exercise intolerance, which is not exactly clear in terms of physiopathology, because usually oxygen can be withdrawn after a couple of days, but some patients are still extremely dyspneic, and it has of course it has an effect on the things they can or cannot do, and whether or not they can go home because they're too dyspneic to do everyday actions. What we also found is that we in our Hôpital, I didn't show the whole list of units that we had, and I didn't talk about the rehabilitations unit, but we also had 2 rehabilitation units in the hospital that were converted for COVID activities, and about 30% of the patients that we followed after ICU, they ended up being discharged in one of those rehabilitation units, usually for a short amount of time, around 1 or 2 weeks, but that was because they progressed very quickly. But we found that it was probably very beneficial for the patients to have this these 2 weeks of rehabilitation, because, like I said, some of them were really, they appeared to be fine when they were on the chair, but once you would try to have them do something, you would realize that they were really it was pretty difficult, and most of them really benefited from those 1 or 2 weeks of rehabilitation just to be put back on the right tracks, so to speak. So of course, one of the concerns is about rehabilitation is about safety of the staff, especially because when we're talking about rehabilitation in post-ICU, we're talking about tracheostomized patients, and all the taking in and off the ventilation or the inner cannula and things like that. These are exposing procedures, and also rehabilitation. A good rehabilitation program would involve psychologists, would involve dietitians, and this. We had the issue of these people who were not involved in the ICU before, and they had a lot of concern about, like, is my job, I know that my job is important, but is it important enough so that I would take that kind of risk to go see those patients that are still maybe contagious? One of the main issues is that we currently don't know how long a patient is contagious, and that's a real question that needs to be answered, because right now the problem also happens for people who are going back home and that would need physiotherapy at home, and it's really difficult to for the physiotherapists that work outside of the hospital. They don't really know if they should take care of those patients or not. It's really difficult to have things organized because of that. And the question of how long is a patient contagious has not really been cleared yet. The problem is that one of the difficulties is that our main way to diagnose the virus is through a PCR test, but and we know that some patients have a very prolonged the PCR remains positive for a really long amount of time, and especially in critically ill patients. There's this article that I referred to here that was published a couple of days ago, and they showed that in critically ill patients, more than half of them still have a positive PCR after day 28, which is not what we have found in our experience. But that's what they found. Of course, a positive PCR does not mean that a patient is contagious. It could only mean that there is some sort of residual DNA particles that we found. Doesn't mean that the patient is contagious, but that's really a crucial question that has not been properly answered, and that's really a problem for the implementation of rehabilitation protocols. So my hospital has issued local recommendations that are rather pragmatic, and what we say is that after 24 days after the end of the symptoms, the patient is not considered contagious anymore. Which makes it easier for us, but there's still an uncertainty about whether, sometimes the patient still has a PCR and then positive PCR, and then it's always complicated to conclude. But what we do is that we've kept within the hospital, we're still using personal protective equipment, especially for a patient with tracheostomies. And we have detailed written protocols about how we should do such and such intervention and what sort of protection we're using for that. For example, for all that's related to tracheostomy, we use a face shield and above the mask. But that's really a problematic question. That's still a problem. So most of so I think that the most important message from our experience would be that you should increase the number of beds, you should increase the number of ICU beds, and you should increase the number of re-education beds after that. Right now, the problem in France, we're stepping down in the number of ICU beds because we have less patients, but there's a real traffic jam in re-education units because a lot of patients require re-education, ICU patients, but mostly geriatric patients and older patients who have been hospitalized, not in ICU, but that are too tired or too sick to go back home, and they need re-education, and there's a sort of crisis in the number of beds in re-education right now. So one of the main message about how should you take care of patient, I think it's good to stick to the best usual standard of care and what you know to do well. This is what you should do, and don't change Of course, there are some things in our practice that we would have to change because of this huge amount of patients, but we still should do what we know works for the patient. And I think early tracheostomy is not a good idea. We should tracheostomize patient as usual, unless your healthcare system has a way to appropriately take care of tracheostomized patient. If people are trained for that, and if you have a facility that would make you able to empty ICU and properly take care of those patients, then do it. But I think it's dangerous to have an early discharge of a tracheostomized patient in a unit where people don't know how to deal with ICU tracheostomized patient. The good news is that it's not so bad. People don't have a lot of, patients don't have a lot of ICU acquired weakness. We don't see a lot of real weaning problems. So I don't think it is necessary to increase the number of extremely specialized post-ICU units, but rather we should increase the number, maybe the more specialized weaning, normal weaning units. That would be a step-down unit from the ICU, but just to do regular normal extubation for patient. And also I think what should be implemented is a way to make sure every patient get a minimal rehabilitation program, because as we've seen, a lot of patients have had a dramatic weight loss. They have a dramatic muscle loss, even though the muscle strength is rather good. What we see is that a lot of patients have a real effort, intolerance to effort, and they have real difficulties to perform everyday actions. So increasing, everyone think in that kind of crisis, everyone thinks about how we should increase the number of bed of ICUs, but we don't automatically think we have to also organize for after that, and we need to organize to increase the number of rehabilitation beds. We should provide healthcare workers with clear guidelines about contagion safety, and it is not optimal at the moment. And since we're now seeing more patients getting out of 30, 40 days of mechanical ventilation, we're starting to see what I call complicated survivors, people with real chronic critical illness syndrome. We should prepare for that. If your country does not have a lot of specialists in that, maybe you should prepare for that. But again, I don't think it's going to be that many patients, because most of the COVID patients would do 2 weeks of ICU and then they would get better. So this is our main experience. Thank you.
So maybe I can start. And first of all, let me thank Inês Sanches for this initiative, and the Portuguese Society of Pulmonary for having me in this webinar. And I have to say that I really appreciated your presentation, Elise Morawiec. It was really fantastic. And I have a lot of questions with me. And first, I would like to put in perspective a little bit about the experience that I heard from Italy and from the UK. And I'm following you absolutely. I believe that early tracheostomy should not be done, but that what's happened in the UK. So I think 2 days ago, I was speaking with Anita Simons and with Nick Hart from London, and they established both in the Brompton and Guy's and St. Thomas an early tracheostomy protocol. I think they were a little concerned about the Italian experience, but anyway, that's what they thought. So they had a lot of tracheostomized patients to take care after the ICU, which I believe maybe it's not the ideal situation, as you mentioned. And then in Italy also, they were mentioning about high mortality, like 15% of mortality in this context of post-ICU, but perhaps for the, you know, not the early survivors, like you said, but the complicated survivors. Mm-hmm. Do you have, your protocol, I think, is quite reasonable for not doing a tracheostomy because of what you said about the concerns of the aerosolization, the risks, and even for the patient, the management of the tracheostomized patient. One question also about the context of your Pitié-Salpêtrière hospital, which is a referral, a huge hospital. Could you explain us a little bit about because I think maybe some of us would not understood what the difference between the post-ICU rehabilitation unit, that's the one I believe you're working in, and what you call more simple weaning unit, simple weaning center. Could you expand a little bit on that?
Yeah. So the issue was really, are we going to have enough ICU beds? And so we expanded up to, I think around usual time, there's about 100 beds, ICU beds in La Pitié, and we moved that to 120. And after that, we were short on beds, ventilators, and staff. But we still needed to have more, and we found that we could have more by having a sort of smaller structure that would be less staffed and with less resources. And so we did this, what we called weaning unit, which was not for complicated weaning, just regular weaning. And for example, a patient who would need 2 weeks of ICU, the first week it would be very severe, would need prone positioning, dialysis and things like that. And the second week things are getting better and it's not so bad, and it's the weaning phase, and we would transfer him into the other unit for that. And so it's like an ICU, but not so. And that allowed us to work with to part of the people who were working there were not ICU nurses. There was a part of them were ICU nurses, part of them were not ICU nurses, and they sort of worked together. It was a bit challenging. They didn't have the whole equipment of an ICU, but that allowed us to have more beds in total. And the other unit was an already existing unit that specializes in difficult to wean tracheostomized patients. And we're right now we're taking tracheostomized patients that were some of them had early tracheostomy in the units they were in, and they're not as severe as the patients we used to have in normal times.
Can you tell us a little bit what is the percentage? Because we heard a lot about phenotypes, so we discussed in a previous webinar about the different ARDS phenotypes, the different phenotypes of the moderate cases. And in your experience in Paris and in Pitié, what are the profiles of the patients that go to the ICU? I realized that you had not so many ARDS in your series. That's what I understood. But could you expand a little bit more about the profiles of the patients that you received in your unit? Is it post-ARDS, or maybe it's not so severe hypoxemic patients? And could you expand a little bit more?
You're talking about the unit for tracheostomized patients?
Yes, yes.
No, they were mostly post ARDS patients.
Ah, okay.
But they were but most of them, I think that the ICU length of stay was about 2 or 3 weeks. So most of them were probably not much more severe than the other ones we had that didn't go through that unit. It's just that those ones had been tracheostomized because where they were, they had this strategy of early tracheostomy, and they were saying, well, maybe it's been 2 weeks and they're still ventilated, we're going to do a trache. It's not that early, but still maybe they could have waited a couple of more days and they wouldn't have needed that tracheostomy. For me, for most of those patients, tracheostomy was not warranted for most of those patients could have been extubated. Now we're trying to see coming people who have had more severe disease, who've been ventilated for over a month, and this is more like our usual population of patients. And in those patients, tracheostomy is more, those patients had longer period of ventilation. Some of them had real weaning problems, but most of the patients don't. Which is a good news, because otherwise, at the beginning, we were very concerned when we started to see that all the first patient needed 2 weeks of 3 weeks of ventilation. We're like, oh, how are we going to do this? But most of them, surprisingly, weaning is not so difficult.
I have a couple of more questions, but maybe Dr.ª Lígia Pires has some also.
Thank you very much, Elise. I loved your talk. And I have some doubts, especially about the length and the duration of mechanical ventilation. Here I have some patients with comorbidities, and usually they say like 1 month, 6 weeks under mechanical ventilation as being hard. Did you have that experience also with the patients with comorbidities like renal failure?
We had, but it's not the main population of patients we have. And of course, like every time a patient with comorbidities, it's more complicated than patient without comorbidities. And we had a lot of otherwise healthy people that just came for the COVID pneumonia without comorbidities. And maybe that's why we have differences. Our experience is different from the experience in other centers, but yeah, most of our patients are about 55 to 60 median of age, I would say, for 55, with no or low comorbidities.
Okay, and what about the use of courierization? We are using a lot. We never use so much courierization. Like,
yeah, we were on the verge of no more muscle blockers in France, and we had warnings about shortage of lots of sedative drugs and muscle blockers because of the huge. I think that the consumption went up to 400 or 800% for some drugs.
yes,
Because of high number of patients, but also much more. Much higher dosage per patient.
Yes, that's our experience also. And about the tracheostomy, what do you usually perform? Is it like percutaneous or the chirurgical tracheostomy?
Percutaneous.
You're on ICU.
Yeah, in our ICU, percutaneous. That's what our scientific society recommend. And as a physician involved with a lot of tracheostomized patients, I think it's way easier to manage percutaneous tracheostomy, because surgical tracheostomy have more local complication. There is always a leak, and it's way easier. And one of the problems that we had is that since a lot of patients are a bit overweight, and also I think also because the surgeons had nothing to do, because all their activity, the intensivists had a lot of work to do, and the surgeons were very available. So a lot of the early tracheostomy were surgical ones, which was another problem I think for me. But we've seen much more surgical tracheostomies than usually. I don't think COVID is a contraindication to especially if you don't do. Of course, there was a concern about there are more people, and the bronchoscopy part would bring more exposure. But I think if you don't do early tracheostomy, probably later on in the course, if you only tracheostomize patient after 3-4 weeks of mechanical ventilation, the risk is much lower anyway. So I think we should really not change. Like, the situation is already complicated because of the large number of patients. I think that the last thing to do is to change all of our practice, and we should really stick to what we do well, because then everything becomes very complicated. So we also change everything we're doing. So
And what about the safety? Did you manage to put a negative pressure in all the ICUs? Was it possible?
Yeah, it was not technically possible for us to put everything in negative pressure. We only had 2 out of our 15 rooms. We only had 2 negative pressure rooms, and our ICU, like most ICUs, was slightly positively pressured. So what we did is that we sort of inverted the pressure, so it was only slightly, you could not be considered a negative pressure, but it was not a positive pressure anymore, and that's what we did in all of the ICUs. And we at the beginning we were the hospital rented or bought portable filters, but very soon it was not enough because we had maybe 15 of them, and then we had to do 120 beds, so it was not enough. So what we eventually do was to open all the windows, and I don't know, it's in Portugal and France, it's not legal for hospital. In hospital, we cannot have open windows because of the risk of people jumping out of the windows. So we had to sort of change all of that, and to remove all the controllers on the windows to be able to open them wide. And we had a few members of the staff that were contaminated, but not more in the ICU than in other units of the hospital. So I think all the measures we took, the PPE and all the measures we took and all the protocols we did to reduce the risk, I think they were efficient.
Okay. And just one more question about the delirium. You know, I work in the follow-up post-intensive care clinic, and I'm trying to understand what will be the future of these patients, especially not about psychological, because here you have I think it was low, you had very few patients with post-traumatic stress disorder. But I think maybe at 3 months you will have more.
Yes, I completely agree. I think what the numbers I told was only people that were already diagnosed, and we sort of we did this evaluation thing. Like I said, it was mostly medical students that would go in the unit and try to get the information from the team in place. So these data are probably not as precise as they could have been. But you are right, it's a major concern. I think there's a huge trauma for the patient, and especially the patient from the beginning that were put on sedation early on, and then they woke up and the whole world has changed, and they only see people with masks. Yes. And they don't understand what's going on, and they can't see their families because the visits are not allowed, and that's a major problem. And we could see that once we started to have to implement visits and have relatives coming over, that would make a huge difference in the patient that were having delirium. Seeing their families would really make it much better. So that's a real concern. I don't know how it's going to turn out. We have a team of psychologists that is really doing an amazing job, and they're trying to see a lot of people. We've tried to do video conferences with psychologists, telephone meeting with psychologists anyway, so that more and everyone can be reached, with the families as well, because it's really difficult for the families not to be close to their relative for so many weeks. And the whole context is really traumatic for everyone, and I think there's going to be a lot of work to do in that area. And one of my concerns also is that there are a lot of people that are being discharged out of the ICU very early, next day or 2 days after their extubation, and they go into a regular medical ward where people don't always have the culture of rehabilitation. And especially in the whole context, and everyone has too much work to do and too many patients to see, and we were very concerned that people would not get proper rehabilitation care in Neste. And we're trying to make sure everyone sees a physiotherapist, everyone sees a nutritionist, because we've seen those tremendous weight loss. But it's really difficult to put together because there are so many patients. So I think in one of the preparations, because we don't know what's going to happen, is going to be a second wave, or if some countries that have been not too touched like your country, I think you're getting ready of maybe things would get worse. I think it's really important right now to think not only about how we're going to take care of the patients in the ICU, but also how we're going to take care of the patients after they get out. And my concern is that a lot of patients are being discharged home without proper evaluation. What we also did is we're trying to implement a screening tool for clinicians so that they can have alerts on some things. If a patient has lost that many percentage of body weight, or if he's not eating that percentage of its plate, if they cannot perform that task, they should get a specialized consultation before the patient goes back home. And because we've already heard about people that had been discharged home, and they're not really doing well at home. So that's a point of concern. But also the fact of having followed all these patients coming out of the ICU, most of them are doing well, and they are recovering pretty fast. So I think they only need really to be put back on tracks, and having someone to make sure that everything is doing well and is going to the right direction. I don't think that we necessarily have to have everyone having a complete rehabilitation program, because that would be impossible. But just to put in place a minimal program, just to make sure everyone is going into the right direction, and to be able to identify the patient who don't. There's still a lot of questions, especially about why some of the patients are so tired and so unable to perform simple tasks. Is it because of just the general fatigue, the weight loss, or is it because of some kind of respiratory involvement? You know, a lot of patients have had thromboembolism, and so we have not seen a lot of fibrosis, for example. And so most of the patients seem to evolve well on the parenchymal aspect, but some of them are still have a lot of dyspnea, and we don't really know why. So this is going to be investigated in the next couple of months, and that's going to be very interesting. But yeah, I think some patients really have to be followed up. But the good news, because there are still, you have to see the bright thing. The good news is that most people have a fast recovery once they get out of the ICU, and they have minimal rehabilitation. They seem to be going quite quickly in the right direction. But of course, that would need follow-up. Now we're sort of trying to figure out how we're going to organize a post-ICU follow-up consultation, or that's another challenge for us now. But that would be very interesting to see how this evolves in terms of dyspnea, nutrition, psychological sequelae and stuff like that.
I would like to come back again to this weaning. We were here in Portugal a little concerned about the difficulties that we would have with weaning, and it's very good news that you're giving us, and a little bit in keeping with what we heard from the UK. Apparently, these early survivors from the ICU don't have a very difficult weaning situation. You also mentioned that you didn't use a lot of NIV for the weaning of these patients. I wonder if you're using high-flow nasal cannulas, because you have been involved in this seminal paper of the New England with Fratt, first author. So I would love to hear I'm a big fan of high-flow nasal cannulas, by the way. So I wonder if you have used the high-flow nasal cannula in this weaning phase, but also in the acute phase. I would like also to know about your experience in the wards or maybe in the intermediate care unit when these hypoxemic patients come. Are you using high flow nasal cannula as a first line intervention as well?
Yes, we do. That was a process actually, because of course at the very beginning it was, and it's still unclear. What is still unclear is the risk that is associated with high flow, and whether or not it's a higher risk or not than conventional oxygen if you use a high flow. And there are no direct data that can answer that question. So at the beginning we hesitated on using it, and we at the beginning decided not to. But after first of all, like reading, trying to see what the literature, there are no paper that compares the aerosolization and the infectious risk of high flow, but there are some papers that compare the dispersion, and more general things about aerosolization that would actually I think, after having thought about it, I think that I'm not convinced that the risk is higher, the aerosolization risk is higher with high flow than it is with conventional oxygen. So I think it's not a problem to use it. And as we've seen, once the patient is intubated, you know that you're going to go for over 1 week of mechanical ventilation in most cases, and the patient is really severe. So avoiding intubation in those patients is really important and would really change the prognosis of the patients. So we now use, when we've been for some time using high flow at the acute phase of COVID pneumonia, with success in some patients, without success in other patients. What we've seen in France, and also I think that was the experience of our Italian colleagues, is that CPAP has been used a lot in the acute phase and appears to have given good results. So this should be investigated more, because as you know, we didn't used to use CPAP as a treatment, but this was something that was this idea was sort of getting popular. And I know that our team, we had we planned before the COVID, we had a plan of to start a study about using CPAP for hypoxemic respiratory failure, and I don't know, for some reason a lot of people starting to do CPAP in the COVID, and it seemed to have given good results. That's the experience that we have, and that's the experience also that I've heard from colleagues. So definitely that's something that should be investigated in the future. And to answer your other question, we used also, but not so much high flow in the post-acute phase, because like I said, most patients didn't really needed it, because once they were extubated, not a lot of patients were in the at-risk category in our experience, and we didn't use a lot of high flow after extubation.
Two remarks about this point. One is a recent paper about the usage of a surgical mask on top of high flow. It really reduces the aerosol dispersion. So I think that a lot of people are using high flow with confidence, because the dispersion is not as much as, it's lower than common CPAP with nasal masks. So and the usage is nice. And also, I spoke with people from Italy, especially Stefano Nava, that was a huge fan of CPAP as first line, and he had to admit that really high flow nasal cannula could be also a good option. And the concerns of, the safety issues was not anymore. And there are a couple of more papers about the, the dispersion of bacteria around the beds. It doesn't seem to go very far from, 1 meter. And so it's quite reasonable for the safety of the healthcare workers. So I think that we need, as you said, randomized controlled trials. And I heard that there is one going on in the UK, comparing both oxygen, conventional oxygen, high flow versus CPAP. So hopefully we will have some good data soon, just for us to be more sure about, to decide what would be the first intervention. Another question about the ECMO. You are also an ECMO referral center, and I, from what I understood, you didn't use it so much. Compared to the UK centers in London, I realized that they have like 10% of the ARDS on ECMO, as far as I could get. So you don't have so many cases?
Not so many, but we do have, I think we've had maybe probably 15, maybe a little more patients on ECMO, but that's about it, because we've had about 110 patients, so that's about 10% of patients on ECMO. The thing is, I think it's too early right now to draw any conclusions about the benefits of ECMO. We've had a few patients that we have decannulated and that have really benefited from ECMO, young patients. But we still do have, I think, 8 patients on ECMO that have been on ECMO for over 30 days and don't seem to get much better. So we definitely have more time to draw the final conclusions about the contributions of ECMO. It has been life-saving for those patients, for some of the patients, but for other patients it's less certain. And what is certain is that people placed on ECMO would stay for a very long time in the ICU, and that can be a concern when ICU beds are a rare commodity and we have a lot of patients, because if you after 6 weeks on ECMO, if you still are in a shortage of ICU beds, it's an ethical problem as well. So we need to wait for a couple of more weeks, I think, to have more definite data about ECMO. And but the thing is that it's really, what's been shown in other indication is that it's really difficult to predict what patient to predict the course of evolution of patient on ECMO. Some patients stay for a very long time on ECMO and they end up having a good evolution, and it's really difficult. So it's a difficult question. But we were about 10%, but we are at ECMO centers, so overall in France, the whole I don't know the numbers, the percentage of ECMO.
Okay, so great. Thank you so much for your insights and your work. We really appreciate your time. Thank you.
Thank you.
Oh, thank you for all. Thank you.